of our fantastic interviews with Dr. Michael Holick. Dr. Holick today is going to talk with us about prostate cancer and what he's done about it. Obviously, he's got it. So we need to know more about how he has been working with it and any advice he has for those that could benefit. So, Dr. Holick, why don't you kick it off?
Thank you very much, Carole. So first, I'll give a little bit of perspective, and then I'll share with you my journey and explain to your audience how to deal with the devastation of this cancer and the consequences of the treatment. But the most important message, I think, is 1 in 6 men will get prostate cancer in their lifetime. It's estimated probably by the age of 80, every male will have some evidence for prostate cancer. 15% of men with prostate cancer will have the most devastating form based on what's called a Gleason score. And so what typically happens is, and I encourage all men, even by the age of 50, that they should be getting a routine yearly PSA, prostate-specific antigen, because it's very stable. And only if it begins to rise, you begin to worry that this could be due to prostate cancer. And so it's the best method to identify it early and intervene early. Because if you don't intervene early, you will have the consequences that I am now undergoing. So to begin, basically it was November of 2021. I had already celebrated my 75th birthday. I was extremely happy, active, cycling 35 miles on the weekends, have gardening. And then all of a sudden, I went to my primary care doc. And my father had prostate cancer, the benign form. And so I knew that I should be careful about this. But then COVID hit. Normally, I was seeing my PCP every year, getting my PSA, and it's always been rock stable. So when COVID hit, and I missed that appointment because it wasn't available, I must admit, I just didn't think immediately as soon as he was available again to get it done. And so it took 1.5 years. In that time, it turned out my PSA went from 2 up to 13. Now, you would think that's not really a big deal. And indeed, my good friend is a urologist. And he said to me, after evaluating me and my prostate, because normally if you have prostate cancer and you do a prostate exam, you can feel kind of bumps on the prostate, right? But men also, as they age, their prostate gland hypertrophies, it gets bigger. And when it gets bigger, it makes more PSA. So after evaluating me, he said, Holick, I don't think you have anything to worry about. It's a little bit bigger. You most likely have hypertrophy, and the PSA totally explains it. But let's do biopsy just to be sure. And so 22 biopsies were taken, and all of them basically were involved.
Why so many?
Why so many? Because you want to really pick all of the areas on the gland, because you don't want to miss anything, right? I mean, what's ideal is that for men whose PSA is beginning to rise, they should get this biopsy, because if they only find a tiny amount in one little area, you can irradiate that area. There's all kinds of things that can be done. It's called stage 1 prostate cancer. But if you let it go, this is a true monster in your body, and it will eat you alive. And what they do is when they take the biopsy, they look at the cancer cells and they want to see, are they kind of slowly growing or are they super aggressive, what's called anaplastic. And those that are anaplastic grow like crazy. So I have a Gleason score of 9. The highest is 10, meaning that it's the most aggressive in the sense that it will continue to grow in your prostate, take over your prostate gland, and then begin to move out. And it desires to be everywhere in your body, especially in your bone. So after having the biopsies, my urologist called me back frantic, telling me that, yeah, not only do I have prostate cancer, but it's Gleason score 9, and that almost all the biopsies were positive. So immediately I had an MRI to find out where the cancer was in my prostate and was it extending out. And sure enough, it was already growing out into the nerve bundle. So by definition, right, stage 1 and 2, the prostate cancer is within the gland, but and so having surgery, for example, can be curable. But stage 3, now it's extended out, and you have no idea where it's gone.
Wow.
And so I then had what's called a PET scan. And what a PET scan does is it can light up any area of increased activity. So they looked at my lymph nodes and they looked at the whole area, and happily they did not see anything in my bones and did not see anything in my lymph nodes. It doesn't mean that it's not there, but at least it wasn't there in any significant way.
Right.
So then, of course, you have to figure out what to do. So I'm a doc, I'm an endocrinologist, and I've seen lots of patients with prostate cancer.
Right.
And so now I'm a patient. And
that must be a really unique experience.
Right, it is. And so the first thing is to get the diagnosis. I mean, when you hear for the first time that you have cancer, even if it's a bit more benign cancer, your whole life just kind of, at least for me, stopped and began to realize that I'm mortal, right? And that this monster inside me wants me. And so I'm going to do everything in my power to prevent that monster from really destroying my body. I knew what was coming next. So I immediately got to see a surgeon, because that's an option, is to have your prostate gland taken out. The thinking being that if you debulk the area, so you take out the prostate, so most of the cancer is gone, but we know that it's already extended out, and we don't know where. And so you can definitely have that. And it was suggested to me that typically they don't do that over the age of about 70 years, but they saw that I was very vigorous and healthy. So they said they would definitely consider surgery for me. And then I met my oncologist.
What does it mean that they don't do that over the age of 70 or so? Tell me what is going on there.
Well, what's going on is that often by this time, men, can have respiratory issues. I mean, they may have more serious complications from the surgery than what the surgery is worth. And so, and that they have a much harder time recovering.
Okay.
And they have severe incontinence, and a lot of other issues, including severe erectile dysfunction. So as a result, typically they don't do surgery after 70 years, but they were willing to do it for me. And then I met my oncologist. And what was really amazing, and she was my good friend at Boston Medical Center. As soon as I entered her office, she looks at me and she says, "Holick, this is curable." Now, I was pretty sure that's not, okay? But to hear that was just such a relief, right? And then I went over to Dana-Farber because I was a Boston Medical Center doc, so it was probably not appropriate to be at my medical center. And I went to Dana-Farber, which is a superb cancer center, and Alicia Morgans is my oncologist. And it turns out that she's published in this area. And she, of course, provided me with all the literature on what the consequences are of the surgery when you have stage 3, and the medications that you're going to be on. I already knew that since it was not contained within my prostate, if they took my prostate out, I'm still going to have cancer in the nerve bundle and maybe in my lymph nodes. So even if they took it out, I would still have to get radiation therapy and chemotherapy. So I decided that, to me, what made the most sense is to go the route of having androgen deprivation therapy, which I'll explain in a minute, along with radiation therapy, and then what we call brachytherapy. And I called brachy, BRACHY therapy, and I'll explain in a minute a little bit about this. And by the way, for your listeners, if you want more information on my Facebook, just Dr. Michael Holick, I'm now sharing my journey from the day I received this diagnosis and how I've been dealing with all of the issues. And so I'm right now up to chapter 15, and chapter 16 will be on probably by tomorrow. And so I knew I'm in trouble, because I knew that what's going to happen is they're going to put me on medications that prevent me from making testosterone. And my oncologist told me, and I knew what the consequence was, because I had seen a lot of men with prostate cancer, to help them for their bone health, which we can talk about a little while later, and what the consequences are of having no testosterone. Because I'm an endocrinologist, so I saw a lot of men with hypogonadism, right? Low testosterone. Well, when you have no testosterone, your muscles begin to just become flabby. You become very kind of weak. You wind up becoming listless, meaning that you really just get up in the morning and you really don't want to do anything. You want to become a couch potato, basically. It changes your body habitus so that you wind up with a big fat belly. You wind up with gynecomastia so that you actually develop breasts. But for a male, there's something else that happens, which is absolutely devastating. And I was told this, but I already knew the answer, which was, Holick, when you're on androgen deprivation therapy, meaning you have no ability to make testosterone or androgens in your adrenal glands, and I'll explain some of the medications for this in a minute, is that your testes will become pea-sized by the time you complete your treatment. No male wants to hear that. And that there's a good chance that your penis is going to shrink in size. Again, not something any male wants to hear about. And of course, severe erectile dysfunction. So, January 1, 2022, as I'm going to be seeing my oncologist in 2 weeks, I immediately start to intervene. Because when you have no testosterone, you don't just wake up one day fat and flabby, right? That happens over time. And so I decided to intervene. And I intervened by making my New Year's resolution for 2023 is to walk 5 miles every day and to increase my personal training, weight training, from once a week to twice a week. And then I wound up seeing my oncologist and gave me Lupron. Lupron is a drug that actually initially stimulates the brain to make FSH and LH to actually increase the production of testosterone. But when it's around for a long time, it was learned a long time ago that Lupron will then cause the brain, basically, with your hypothalamus, to say, I've seen enough of you, and I don't want to see any more of you. And so as a result, you become resistant to its positive effect. And now it has a negative effect. And it shuts down the ability of your pituitary gland to make follicle-stimulating hormone and luteinizing hormone. These are hormones that are critically important for maintaining estrogen production in women and testosterone production in men. But my oncologist told me that something else you have to be concerned about, which is that your adrenal glands, which make cortisol, right, that right? That if you get stressed, you make more cortisol to help make you feel better. It gets your liver to make some release glucose. I mean, it keeps you going. Saying that you can't have your adrenal glands making androgens because it'll feed your prostate cancer cells in your body. So so they put me on a medication called abiraterone. And this medication is supposed to directly inhibit androgen production in your adrenal glands, but not have any effect. So affect androgen production in your adrenal glands, but have no effect on cortisol production. So it sounds like an ideal drug. And so they put me on it. And so now, a couple of months later, I mean, by 3, 4 o'clock in the afternoon, I was really feeling excessively tired. They had put me automatically on prednisone, 5 milligrams in the morning, presumably because they said, well, if it has any effect on your cortisol, that this will take care of it. Well, being an endocrinologist, right? Typically, if you want to check your adrenal function, what you need to do is to get an 8 a.m. cortisol. The reason being that the body wakes you up at around 3, 4 o'clock in the morning. Your pituitary gland starts making adrenocorticotropin hormone. It goes to your adrenal glands to now make cortisol so that when you wake up in the morning, you're raring to go. Your tank is full and you're ready to go. And I was feeling so exhausted in the afternoon, and I realized that prednisone, when you take it in the morning, like at 5 in the morning, because I'm up early, it has a half-life of 3 to 4 hours. Mm-hmm. So by the time you reach 5 o'clock in the afternoon, you have zero ability. You have no adrenal function. And so I realized I was Addisonian, that I was adrenally insufficient. Okay. And so that was a major complication. So I went on 2.5 milligrams of prednisone in the afternoon, being a doc, knowing that, because that's how you treat Addison's disease. What President Kennedy had is it's 10 milligrams of hydrocortisone in the morning and 5 milligrams in the afternoon. The problem is this medication causes insulin resistance. And I wound up with type 2 diabetes. All right, so now they said that we have to give you radiation therapy, but we want your prostate gland to shrink by about 50%. And it should do so being on abiraterone and on Lupron. And so they waited 3 months and initiated radiation therapy. It's what's called image-guided radiation therapy, which is really important. And I underwent 28 treatments. So I would go every day, 5 days a week. Now, the problem with radiation therapy, and they give you this long list of complications, is that it can cause gastrointestinal bleeding. It can cause GI upset and pain in your colon. It can affect your the perineal area because it could burn your skin potentially, right? And so what they do is they put you on what's called Miralax, which I think people who have constipation know it well. It's a resin, and I had to take 2 tablespoons a day in like 16 ounces of water. And what it does is that it stays in your colon and it absorbs water, so that it makes the stool very loose. And that's important because you want to evacuate and have your colon flat as you're beginning to get irradiated. The second point is,
Michael, I would like to interject something here, and you can set it aside for discussion later, but one of the things that you mentioned way early on was they, excuse me, They don't do the surgery with people over 70, way up at the beginning of your talk, all right?
Yep.
Leo, my husband, is 95. Okay.
And
And much of what you have done has been prescribed to him without the knowledge base. I mean, he's a brilliant man, but he does not have endocrinology knowledge, nor does he have doctors like that. And there are some really big side effects of therapeutic things he's been on. And the thing that just totally grabbed me was about the muscles.
yep.
We had a very reasonably active, physically active man who went from being quite active to almost not being able to get up out of a chair.
Right.
And except for physical therapy treatment, there really was not any mention, one way or another, of the drugs that this man was taking affecting his muscles.
Wow.
So I am wanting to incorporate some, maybe they don't generally do these things with people over 70, but it's possible in some cases they do, and these need to be looked at kind of like in parallel to see, well, if you're 90 and have this done, what are the possibilities? Because people are living longer and people are reasonably healthy. And anyway, so thank you for listening to this part, but I really appreciate your talk, and I want to interject some pictures or something of side effects of very different ages.
Yeah. But these side effects will affect a 50-year-old just like a 90-year-old.
Yeah.
And like I said, what I did, right, because, just thinking, right, is you don't wake up one day hypogonadal and having no muscle function.
Right.
And so if you use it, you won't lose it. And that's why I was so aggressive in intervening and walking every day, at least 5 miles every day, and lifting weights twice a week.
You knew to do that. You knew
Right,
to
exactly.
do that.
Right, exactly.
And my husband did not know to do that.
Right, and nor was I told to do that.
Right.
This is all because of my thinking and my experience in this area. Right.
Fantastic. Well, carry on.
So now I'm getting radiation therapy, right? And so the other issue is that the radiation is going to hit your bladder. And so it can cause bladder bleeding and cause all kinds of problems. And so what they recommend you do is that you have to drink 16 ounces of water before radiation therapy, because you would think if you drank a lot of water that your bladder would go down. No, it goes up. And so it gets out of the space where the radiation is hitting your lymph nodes and your prostate gland. So now I decided, okay, I'm going to now walk minimum 5 up to 10 miles before I got my radiation therapy. So I got in there at around 4:30, 5 o'clock in the morning, and I walked for about 2.5 to 3 hours, and then immediately evacuated because I have now all of that Miralax, right, and soft stool, right? And walking so much stimulates your colon. And so it was really effective. And so I totally collapsed my colon. I drank 32 ounces of water to be sure that I was totally hydrated. And so 5 days a week, 28 sessions. Every week, they would stop at the end of my session and say, so how are you feeling? Are you having any gastrointestinal bleeding? Are you having any pains? And I said, I've been feeling fine. And so after my 28th session, they sat me down again and asked me the same questions. And so then I said to them, I've not had any side effects. I said, are you sure you turned the machine on? And they said, oh, don't you know, your insurance company doesn't cover that. You have to pay extra. But the message is, right, is I just won't let that monster in me ruin me. And you have to intervene at every level. So now I knew the next thing that's up is what's called brachytherapy. And what brachytherapy is, and this is done for both breast cancer patients and other cancer patients and prostate cancer patients, is what they do is that they will put these little tubes into your prostate gland, and then they put in super high radioactive material and keep it there for about 10 minutes to blast your prostate, so that if there were any cells left, because cells that are rapidly growing are more sensitive to radiation, that is the concept. And if you go back and look at the literature, which I read very carefully by the radio-oncologist that was my doc, is that brachytherapy with less radiation therapy was more effective in 5-year survival than having 35 or 40 radiation therapies. And so that was why I went along with it. And again, I prepared myself for this, and again, had no complications from it. All right, so now I have diabetes, and typically I've never had diabetes, but there's a strong family history. And so I'm on the 2 doses, 5 milligrams in the morning, 2.5 in the afternoon. I knew I couldn't stay on it, so I had to stop. And then I weighed 164 pounds, which is not that much, I guess, for me, 5'10". But I knew I had to lose weight. I knew that I had to just absolutely remove cakes and muffins and everything from my diet.
All those great things?
Yeah, and I did it instantly. I mean, you just have to be focused. And I did. I immediately stopped. And I wound up, instead of having lunch with some kind of a sandwich or whatever, is only wild-caught smoked salmon with, and within about 3 months, I lost 10 pounds. And my diabetes no longer exists. So I no longer have diabetes. Okay, so now there's a new problem arise, which is that I was concerned that now that I've had these treatments and the Lupron is going to continue, right, for up to 2 years. And I was told, and I knew it, is that if you've been on Lupron for that long a time and your brain has been shut off for that much time, it can take years, if ever, for your testosterone to come back. Again, no one wants to hear that, okay? So it turns out that Lupron, when they inject it into you and it lasts for 3 months, it's really in your body for a much longer period of time. And so I told my oncologist, I said that there's an oral medication that is an antagonist to the GnRH receptor in the hypothalamus, just like what Lupron is doing. But this medication you take orally every day because it only lasts for a day. It's called Regulix. And
spell it, please, Michael.
So RELUGIX, I believe, Relugolix.
Okay.
And by the way, just to tell your listeners, have good insurance. The abiraterone, I take that in the morning. It has to be taken like at 1, 2 o'clock in the morning. You can't have it around with a meal, so you have to have it at least an hour or two before you eat. I take 4 of them every night. I get up at around 1:30 in the morning. Each one costs $100.
Oh.
Okay. Oh, that's nothing. The Relugolix, I asked because I called up my insurance company. I was just curious. It's almost $1,000 for a pill. So I every day am taking about $1,400 worth of medications every day. And my copay is $8 for the abiraterone and $85 for the Relugolix. So, I mean, I couldn't afford it otherwise. And a lot of men can't. And that's really unfortunate. But there's another problem that I wound up having, which is strange. And I don't know if anybody else has experienced this, but I would have a dinner and my body temperature would drop by 10 degrees. I was so cold that there was absolutely nothing I could do to warm up my body. I mean, I would have like 5 blankets on. My wife would be worried about me, thinking of actually having 911 called to get me to the hospital. And I started thinking about this. I mean, I never had this for the past 1.5 years, but now I all of a sudden have it. And so it's likely that the Eucalyptus, which is only supposed to have one effect on your brain, may very well be having an effect on my temperature sensor in my brain. And I can't control my body temperature. In the meantime, I forgot to mention one of the other major side effects for women with going into menopause and having no hormone, right, estrogen, or men who have no testosterone can get severe hot flashes. I was getting up to 20 a day, and they are vicious. Your whole body is in a sweat. Your underclothes are wet, and it sucks the energy out of you. And again, being a doc and a scientist, I wasn't willing to accept this, so I went on the internet, just curious. And out of the blue, I see this device called Cool Cuff. And what it does is when you turn it on, there's a porcelain piece in the center. It goes down to 47 degrees. And what it does is it tells your brain, you're not hot, you're cool, and it shuts it off. And so my typical fashion, I decided, well, it works for me. I would love for it to work for others. And so I started a clinical trial. And so for your listeners, the good news is, because trying to recruit can sometimes be difficult, is that I got permission from my IRB now to recruit virtually so that I can actually virtually consent them no matter where they are in the United States. And I can then send them the devices and be in constant contact with them. But all I can tell you is, for me, it works incredibly well. It costs about $200. It's worth it. And it doesn't completely shut them off, but it will diminish them substantially. And anybody who's had hot flash will know, when you begin to just feel it coming on, don't let it start, because it's like taking a match and just lighting it and then throwing the match into gasoline tank. Once that happens, you can't control it. And so if you can catch it immediately, it makes a big difference. So now what to do about feeling severely cold in the evening? I mean, that I had no clue. And I went on the internet, nobody ever really heard about this. I'll bet you, though, others feel it. So all of a sudden, a week later, after a couple of weeks, all of a sudden I no longer had it. And then a week later, it came back. So now I'm thinking, well, what happened that week before where it was controlled? And it turned out that my wife made chili. And chili contains capsaicin, which is a compound that affects your P receptors. And they have long range effects. And sure enough, if I now have my lunch, every lunch is chili with capsaicin in it. I went on the internet to think about buying capsaicin as pills, but when you read about it, they have major side effects, kind of major GI side effects and other issues by taking too much at one time. But having chili, it's good for my blood glucose because it's beans, right? And for me at least, it works incredibly well. I no longer have my body temperature dropping in the evening.
Wow.
So now I wanted to take it up one more notch. And I decided, right, to really encourage men and women with cancer who really, just like your husband, right? It's just falling apart, right? I decided I'm going to run the Boston Marathon next year. I never have run in my life. And my New Year's resolution for 2023 is to run the Boston Marathon next year. And so I started, like I said, never run in my life. So I ran an eighth of a mile. I thought it was great. Then a mile, that was great. And I kept increasing my distance. By April, I ran 13 and a half miles. And by Memorial Weekend, I ran 20 miles. I'm sorry, 25 miles in a little under 6 hours.
Mm-hmm.
So now I had to be able to get a bib to run the Boston Marathon. And they're not easy to get. And there's a lot of charities associated with the Boston Athletic Association. So I applied to various ones. And I applied to what's called the 26.2 Foundation. It was founded by former marathon winners. And this group encourages marathoning for children and adults, running, any kind of activity for your health, both your physical and mental health. And they had over, I don't know how many applicants, but I told them my story, and I told them that I'm happy to try to raise money, right, for the bib, but more importantly, I want to be an inspiration. If I can do this, anyone can do this. I'm going to be 78 years old when I run it on April 15th. I'm now in training, so I run about now. I could easily go out and I feel great and run 5 miles. And on the weekend, I run about 10 to 15 miles. And will continue to increase the distance. But what I really need is to increase my speed, right? And so I was doing like a 15-minute mile initially. I'm now down to about 14-minute mile. And my goal is around 13 or 13 and a half minute mile for the whole 26.2 miles of the Boston Marathon.
All right. I think it's marvelous. The story that you have told is so filled with information that can be just kind of taken apart by you and by other scientifically oriented people to look at much bigger population. Your capsaicin comment was also, I had read about chili peppers. I have an allergy issue. And having this particular spice in what I was eating is the only thing over a course of more than 5 years that's addressed the nasal passages in such a way that they stop dripping.
Wow, nice. So I'm going to leave you with one more thought about this.
Yes, please.
And this is potentially the most serious complication of these medications, at least for men with prostate cancer and probably for others as well. It's well documented that men with prostate cancer have a 4 times higher risk of suicide. And these medications play in your head. I mean, they can really kind of make it clear to you that the easy way out is just to go to the bright light. Mm-hmm. And that's it. And so I've been, and I have as one of my chapters, explaining about this issue. And it's an important one for people to realize.
It's extremely important. It's extremely important, not just for that person, but for their caregivers.
Right.
To know about it.
And what's most important is we know that men who have no family, that live alone, right, are more likely to do this, right? And so it's incredibly important for families who have, a loved one, brother, husband, grandfather with prostate cancer, to be in closer touch. Yes. And to be sure that, that everything is well, with your loved one. And on the opposite side is it's really important, but presumably very difficult for anyone to admit that they've been thinking about this. right? But incredibly important. If you don't want to talk to your provider, right, your primary care doc, right, talk to your family, because just releasing it from you can make all the difference in the world and really give you clarity that
Yes,
just makes no sense at all.
yes. I think the no sense at all is also important. I mean, there are people who get these terrible thoughts, and they may or may not try to hide them, but the very fact that they are not necessarily caused by somebody being unkind to them or by circumstances that they might dream up. And if back again to the caregiver, whether it be a family person or a medical person or whatever, realizes that solving the problem isn't necessarily addressing directly what the subject of the concern is.
Right. And it also
Michael,
turns out,
this is beautiful. This is beautiful. Well, I know that. Anyway, carry on. Is that
so if it's okay, is just one more piece about the suicide,
please?
which is that there's what's called suicide ideation, right?
Okay.
Which means that people are having ideas of suicide.
Yes.
That's an important group, but the more important group, about a third of patients that commit suicide, is due actually to intent. It's one thing to think about it, but it's another thing to have the intent to do it. And those are the individuals that are the ones that ultimately you need to focus on. And
Yes.
those are the ones often that are unwilling to seek advice or to explain themselves, because they've already decided, I intend to do this, right? And so again, incredibly important for for anyone with this terrible disease, talk to family. They'll listen to you, right? And make sure that your family members are aware of this and talk to you.
And give everybody a good hug.
No question. It makes a
I'm
very
sorry, it's just kind of
yeah.
like.
I mean, I've been blessed. I celebrated my 51st wedding anniversary with my beautiful, wonderful wife, and she's been incredible. I mean, because, like I said, I was becoming a zombie at night. I couldn't function. I mean,
Yeah.
it was to the point where you're standing, you know that you have to go someplace, and you can't move.
Yes.
And Sally would be there saying, "Okay, move, right, move, right." Or when it came time where I was so cold that I was really hypothermic, is that she would just come to my aid. And so I've been totally blessed and really happy to share all of this. And like I said, it's on my Facebook. All these chapters is to really help men with prostate cancer, but also women with breast cancer. They're going through the same thing.
And please put the word in your book or your whatever about caregivers. All of these people who need care are getting it somehow or not. And the more knowledge that can be expended out there to share how to help these people is really important.
Yeah. And I think I had mentioned to you, and I have a flyer now that if people are interested in wanting to support my run, to be part of the family of donors, I'd be most grateful. And I think you have the URL,
We will post
QR
that
code for
on
that.
the Grassroots Health website, Michael, very
I
shortly.
appreciate that.
Very shortly. So people
And
can
now I have a new goal for running the Boston Marathon, and it's in the honor of my brother, who at 75 passed away with colon cancer just a couple of weeks ago.
Yes.
Yeah. Cancer is not your friend. I mean, it is. It is.
I've already been through that decision.
It's a monster. It's a monster, and it literally it wants to eat you alive, and it will do so. But you need to be aggressive against it in any way, shape, and form.
Well, both to tackle it when you've got it, but at the same time, very aggressive in preventing it to the extent that you can. And
or or at least making sure that you get colonoscopy, at least once every 5 years. And if they find polyps, should be even more soon than that. Men, like I said, by the age of 45 or 50, they should start having routine PSAs and don't ever stop. I mean, it was only COVID that did me in. Because I was religious in seeing my primary care doc. So even though I'm a doc, I never want to play doctor for myself. And so I was very happy to see my primary care doc.
Sure.
Yeah.
Well, Michael, I want to invite all of the people that see this to send queries to Carole at grassrootshealth.org, and we will respond to the queries. Most likely certainly we get the information, but we want to know what you've asked and we want to share that with everybody. And then obviously with Dr. Holick, because once you see more, I mean, I'm sure you've already seen thousands of people responding to your information, but this is a gold mine. And throughout all of the whole vitamin D work that I've done ever since I met you back in 2008, there's always this gold mine sitting there and doing things, not just sitting there. So that is so appreciated, Michael. So
my pleasure. Yeah, it's my pleasure. I mean, I thoroughly enjoyed our first meeting in Boston.
That was a while ago.
Yeah, it was a while ago, and and our friendship has continued, and you've done incredible things to help, the health and welfare of people, globally. And some of the time we could probably talk a little bit more about vitamin D.
Of course.
Yeah.
Well, not today.
That's exactly right. Yep. Now this has to be just focused on have a diagnosis. You need to intervene as soon as possible. Yes. Don't become fat and flabby.
And there are things you can do.
Leo.
People need to have confidence that there are things to do.
Yeah, most definitely. I mean, I've been on a webinar for Dana-Farber and a telethon for them, and I've gotten back. Yeah, like you said, I have over now, I think 9,000 or 10,000 followers on my Facebook, and I'm getting emails like from daughters of fathers with prostate cancer say, "Get off your duff and get going. if Holick can do it, you can do it."
Yeah. Well, Michael, thank you for today, and we will get this published very quickly and get the chain started with great feedback that helps people help themselves. Thank you so much again.
Happy New Year.
Thank you very much. And you.
Bye-bye.
Bye-bye.